Senate Appropriations Subcommittee on Labor, Health and Human Services, Education and Related Agencies will please come to order. Today we are having a hearing on the Biden administration's fiscal year 2023 budget request for the National Institutes of Health. Senator Blunt and I will each have an opening statement, then I will introduce our witnesses, and after their testimony, senators will each have 5 minutes for a round of questions. While we were unable to have this hearing fully open to the public or media for in-person attendance, live video is available on our committee website. If you are in need of accommodations, including closed captioning, you can reach out to the committee or the Office of Congressional Accessibility Services. Every day across my home state of Washington, researchers at the Fred Hutch Center, University of Washington, Washington State University, Seattle Children's Hospital, and so many other world-class institutions are working around the clock and making groundbreaking discoveries. Discoveries that don't just drive innovation and economic growth, but also bring families cures and treatments and hope for the future. Discoveries that save lives. Discoveries that don't just drive innovation and economic growth, but also bring families cures and treatments and hope for the future. I am pleased to say this budget request shows the administration understands the tremendous importance of supporting our nation's biomedical research community and continuing our tradition of global leadership here, especially as in the past few years have been such a stark reminder of how the investments we make in research today pay off down the road. The rapid development of safe, effective COVID vaccines was made possible by research into mRNA vaccines we funded in response to Ebola and other viruses, and by a biomedical research enterprise that has been built over decades. And today, thanks to the vaccines and therapeutics that NIH researched to help develop, COVID deaths and hospitalizations are the lowest we have seen in 2 years. However, we are not out of the woods yet when it comes to this pandemic. There is still the threat of new, more deadly variants, especially right now when caseloads are inching up again, but our community's resources have largely been spent down. We need to defend the hard-won progress we have made, and that means passing emergency COVID funding so our communities have the tests and treatments and vaccines and tools they need to keep families safe. This is really urgent, so I'm going to keep fighting to make sure we get it done. And in addition to providing our communities the resources they need to fight this pandemic, I hope we're able to come together this year, as we have so many times in the past, to continue providing our researchers what they need to help us to fight COVID-19 and so many other challenges. Challenges like developing better tests, making next-generation vaccines that are effective against all COVID variants, and understanding long COVID and how we support the millions of people who are living with it. And challenges like the mental health crisis this pandemic has made so much worse, especially for young people, or overdose deaths, which have been skyrocketing due to the rise of fentanyl. Recently, our nation lost a record 107,000 people to overdose deaths in a single year. And in Washington State, opioid deaths increased by 2/3 in 2021. This crisis is tearing a hole in so many communities, so many families. It is truly heartbreaking, and we have to pull out all the stops to get this under control. That's why I'm working on bipartisan legislation to strengthen programs that help our first responders, healthcare professionals, and others on the front lines, and why I want to make sure we continue investing in research here like this budget proposes. Of course, the measure of success against any disease is not how much we invest to fight it, it's how much we are helping patients. For example, when it comes to Alzheimer's disease, that's exactly what we need to be focused on. For patients fighting this disease, the stakes are intensely personal. They are fighting to hold on to cherished memories with loved ones and a feeling of control over their daily lives. And the weight of that fight falls on their family members, friends, and caregivers. With so much at stake in their lives, these families deserve to know the research projects they are depending on are being thoughtfully designed and prioritized for meaningful outcomes and results. This is really important for me, especially when we've increased funding for Alzheimer's research 6-fold since 2015. when the 2025 target date that's established in the National Alzheimer Project Act is just around the corner, and when there are so many other terrible diseases families are desperate for NIH to put more resources into as well. Another important undertaking is the launch of the Advanced Research Projects Authority for Health, which aims to break the mold for how cutting-edge research is conducted, speed up the discovery and development of medical treatments, and support projects that have the potential to transform medicine. I worked hard to provide resources to establish ARPA-H in our bipartisan funding bill earlier this year, and I'm working hard right now to pass the Prevent Pandemics Act to set it up for long-term success. That requires striking a balance to ensure ARPA-H can complement NIH's expertise while still operating independently to nimbly seize opportunities to accelerate innovation and breakthroughs. I'm really focused on getting that balance right, so I'll be asking more about why so much of the NIH budget increase requested by the administration goes towards ARPA-H when it is yet to bring on a staff, and what that means for the other NIH institutes and centers. Of course, at the end of the day, innovation isn't just driven by new programs and new investments, it is driven by people, which is why with as much as we invest in NIH each year and as important as its work is to our families, we can't afford to have this agency's potential limited or its success threatened by bias, discrimination, or harassment in the workplace. We have to do more to address harassment in the biomedical research community, as well as address the fact that the number of researchers of color is too low, and even clinical trials often fail to be adequately representative. These are real problems with real consequences for research, and I've been pressing for progress on this for years. So I've been glad to see NIH working to examine barriers to diversity among its researchers, address how its practices have reinforced structural biases and discrimination, and implement a new policy I secured in this committee that requires those that receive NIH grants to notify the agency when a principal investigator is removed, even temporarily, for sexual harassment or bullying. But more work remains to be done to remove racism, discrimination, and harassment from research, and I will continue to follow our progress here. Finally, before I turn it over to Senator Blunt, I just want to take a moment to note that this will be the last NIH hearing we have with him, and to say how grateful I am, Senator Blunt, for all the work with you on this issue over the years. It's been really great to have a partner across the aisle who really understands why these investments are so important to families in Washington State, Missouri, across the country, and who's really willing to sit down and work in a bipartisan way to make sure we are delivering for folks back home. So thank you so much, Senator Blunt, and I'll turn it over to you.
Well, thank you, Chair. I appreciate the work we've done together. As you said, this is my, in all likelihood, last NIH hearing. And as I've started to look back on the time I've spent in the Senate, one of the things I think will have the most long-term impact is what we have done together for NIH research. You've been a great partner in that effort. We've worked closely with Chairman DeLaura and Congressman Cole in the House, who chair that subcommittee, and they have both chaired the committee during the 8 years we've been doing this work together. The entire committee, of course, was involved, but I'd particularly like to mention Senator Durbin and former Senator Alexander, who were right there at the beginning of trying to see what we could do to change a trajectory that really was not good. And of course, Dr. Tabak, thank you for you and the directors being here with us today. And I think all of you would remember when I became chairman nearly 8 years ago, NIH funding was stagnant and had been for about a decade. But over the past 7 years working together, we've increased that funding by nearly 50%. It was a period of time that, looking back, NIH not only could count on sustained funding, but also having a substantial increase every year. And I'm hopeful and confident that Senator Murray's continued partnership in that commitment will let us do that again this year. And I hope we're able to successfully work together and have a bill this year. I'm disappointed that this budget request reduces funding for 12 of the 27 institutes including the National Cancer Institute and the National Institute of Allergy and Infectious Diseases. The latter, of course, was demonstrated over and over again how important it was during COVID. There are very few increases, frankly, that are proposed in this request. And one like the cures, like the increase in cures is coincidental in that this FY23 year has that number already built in. The only significant increase, as the chair has pointed out, at NIH this year would be an increase of $4 billion for ARPA-H. Now, I'm a supporter of ARPA-H. I'm a supporter of the Secretary's decision to have it associated with NIH, but a $4 billion increase for ARPA-H and no increase for NIH would really verify the worst concerns that people have had about ARPA-H as a competitor to our ongoing research, as opposed to finding a way where the government can and should be willing to take on more financial risk to become a real partner in targeted research outcomes that have a specific short-term goal in mind and help us reach that goal. That doesn't mean we should jeopardize research challenges as big as cancer and Alzheimer's disease, or as small as hearing aids, as we look to build, frankly, on the goal of doing more of what we were able to do in the pandemic. I was also surprised that the budget request failed to take more of the lessons learned from the pandemic into consideration, instead of embracing more high-risk, high-reward science and focusing on projects with instant impact, which proved so successful with programs like RADx. It appears that the budget got bogged down with political priorities that don't quite fit the agency's longstanding mission. This is clearly illustrated with a request for a new center for sexual orientation and gender identity, yet virtually no additional money for the cancer moonshot. NIH is clearly in a period of transition. If there is one lesson to be learned from the COVID-19 pandemic, it's that our nation's success depends on medical research infrastructure across the country supported by NIH. Now's not the time to abandon that goal. Now is the time, in fact, to make it even stronger. And I hope the eventual budget that we propose to our colleagues in the Senate and to the whole Congress will reflect that determination to make NIH stronger across the board, rather than the way this budget proposal looks at NIH. And Chair, thank you for your comments, and thank you for the chance to speak and for holding this hearing.
Thank you. I will now introduce our witnesses. We have Dr. Lawrence Tabak as the Acting Director of the National Institutes of Health. Dr. Anthony Fauci is the Director of the National Institute of Allergy and Infectious Diseases. Dr. Gary Gibbons is the Director of the National Heart, Lung, and Blood Institute. Dr. Joshua Gordon is the Director of the National Institute of Mental Health. And Dr. Nora Volkoff is the Director of the National Institute on Drug Abuse. Welcome to all of you, and thank you for being here today. Acting Director Tabak, you may deliver your opening remarks.
Thank you, Chair Murray, Ranking Member Blunt, and distinguished subcommittee members. I'm honored to be here today with my colleagues representing the NIH. This is a time for NIH and the entire biomedical research community to re-examine all of our efforts. During the COVID-19 pandemic, we were driven by the urgency of the moment. NIH must learn from this experience and seize the opportunity to define a new normal. As acting director, I am committed to new strategies, new voices, and a renewed focus on the future. Now is the time to reflect on what worked and did not work to address COVID and to shape new strategies. Your sustained investment in NIH research set the stage for the new mRNA technology and immunogen design that were key to the development of safe and effective vaccines in an unprecedented timeline. Since these vaccines became available, It is estimated that more than 2 million American lives were saved and more than 17 million hospitalizations were averted. Now we need continued support for a wide range of biomedical fields, including the behavioral and social sciences, to identify and successfully implement better ways of responding to the short and long-term health effects of COVID-19, to prepare for future pandemics, and to ensure equitable protection of our diverse population. And it's not just about vaccines. Our Rapid Acceleration of Diagnostics, or RADx initiative, fueled the development of many new approaches for COVID-19 testing that are being used in our communities. To help ensure that such benefits were shared with those disproportionately affected by the pandemic, we initiated efforts like RADx Underserved Populations and the NIH Community Engagement Alliance. These experiences, along with other NIH-led efforts focused on COVID treatment development, demonstrate the extraordinary value of public-private partnerships. The NIH can build upon the momentum of the COVID response and apply it to other challenges through the Advanced Research Projects Agency for Health, ARPA-H. Thanks to your inclusion of key authorities and funding in the omnibus, NIH is beginning to frame the basic administrative infrastructure for ARPA-H. This is a key first step in creating a permanent home for the strategic partnerships that are so urgently needed to address cancer, diabetes, Alzheimer's, and many other diseases. But we can't stop there. In addition to new strategies, biomedical research needs new voices. A growing body of evidence demonstrates that inclusion of diverse perspectives yields better outcomes. In the clinical setting, diverse medical teams provide more accurate diagnoses and improved health for patients while building trust. We do better science when we have a diversity of scientists from different backgrounds and communities, scientific fields, and various career stages. NIH continues to prioritize, fund, and empower early-stage investigators so that they can succeed as independent researchers. In 2021, we reached an all-time high of early-stage investigators funded, 1,513. The passion and commitment of our scientists is matched by the voices of people living with a wide range of diseases and conditions. Conversations with patients and their advocates are sometimes difficult, but those are often the discussions that teach us the most. From the AIDS advocacy groups of the 1980s to today's groups for autism, ME/CFS, long COVID, and many others, these voices have refused to be ignored, and ultimately, all of us benefit. This is a moment for renewed focus on the future. I spend a lot of time encouraging early-stage scientists, but I also like to think about the importance of engaging elementary school-age children like those my wife has taught for over 40 years. During the COVID pandemic, exposure to the importance of science has become a big part of many of their lives. Past pandemics have inspired young people to become scientists, but the images they saw were usually of older men who looked pretty much like me. Hopefully, today's kids are seeing more scientists who look like them. Still, we need to do better. Our nation needs all the bright minds we can find, and I hope you will continue to work with the NIH to make this happen. Thank you for your time, and my colleagues and I welcome your questions.
Thank you very much. And I realized that as I was going through the list of panelists in front of us, I skipped Dr. Richard Hodes, as the Director of the National Institute on Aging. Welcome to you as well. We will now begin a round of 5-minute questions of our witnesses, and I ask my colleagues to please keep track of the clock and stay within your 5 minutes. Dr. Volkoff, I wanted to start with you. As I mentioned in my opening remarks, across the country, overdose deaths continue to rise dramatically. Last year, they spiked in my home state of Washington by 30%, and much like the rest of the country, were really driven by fentanyl. This is really a national crisis, so we've got to be using every tool that we have to support our communities, including fentanyl strips, which Secretary Becerra mentioned at his hearing here a few weeks ago. The research I've seen indicates that those strips, which are used to detect fentanyl in drugs, are an effective overdose prevention tool, but they require several steps to use them, including chipping off some of the pill to be able to test it. Can you tell us what the research shows about the effectiveness of those test strips and really Are they easy to use? Can you talk a little bit about that?
Yeah, thanks very much for that question. And indeed, the fentanyl test strips have been tested for sensitivity and specificity. And the data shows actually high sensitivity, and there are only a few fentanyl analogs that are not detected. Having said that, the fentanyl test strips were developed for testing drug use in urines of patients that are being monitored. And so now this is a new application, and as a result of that, there can be problems on how it's implemented. Overall, patients that have used the fentanyl test strips report positive outcomes, and actually in terms of identifying drugs that may put them at higher risk. The research is now ongoing to try to determine what are the optimal guidelines on how to use them, number one. But number two, if the results are positive, what is it that the individual should do in case that they still want to consume them? As you know, there are still multiple problems in terms of making these fentanyl tests available throughout the United States, and there is interest on actually determining and getting approval for some of these tests by the Food and Drug Administration so they can be utilized in healthcare settings, which is not possible at this moment.
Well, are there other overdose prevention strategies that you and HHS hope to roll out in the coming months? Talk to me a little bit about what we're doing in terms of prevention.
Prevention strategies that have been shown to be widely effective is perhaps one of the most important ones is widespread distribution of naloxone. And that becomes actually in some instances a challenge if the naloxone is not available for those that use them. Another harm reduction practice that has generated a lot of attention is the extent to which, because the drug supplies is so extremely dangerous these days, in which safe injection sites could be valuable for patients that otherwise may be at very high risk of overdosing. And while the data is still preliminary in the United States, in other countries, they have shown that in certain settings, they can be quite effective. So there is interest on evaluating them. There's also interest in the community to test other products that may serve as harm reduction. For example, the use of kratom, which is sold as tea and that contains a drug molecule that has effects that are similar to those of buprenorphine, but could be utilized also for decreasing withdrawal depression. So these are more novel, and we don't have sufficient data, but those are things that are being discussed.
Okay, thank you. Dr. Hodes, it is said that science is a marathon, not a sprint. However, Congress has really approached investing in research to treat and cure Alzheimer's disease and related dementias with really a sense of urgency. We have poured resources into this research, $17 billion since 2015, to really supercharge the discovery process with the goal of finding a treatment or cure by 2025. And I'm concerned that NIH isn't positioned to meet that deadline. Given the sheer scale of federal investment, what is NIH doing to deliver meaningful and measurable outcomes that assess its progress towards finding effective treatments?
Thank you for that critical question. And let me answer it very briefly in terms of process and then with some examples of meaningful accomplishments during this time. As you know, we've counted on critical input from the national and global research communities, advocates, et cetera, with our annual summits, all of which feed into a careful identification of milestones, that is, the goals and targets which are necessary to meet our most important needs. I want to take a moment just to thank the staff of this committee for the interactions we've had over the past year to help us focusing these milestones into meaningful, quantifiable outcomes and making them transparent and available. To touch on just some of the examples of important advances, I would point starting with our clinical trials. So, for example, in pharmacologic trials, there are currently 8 studies targeting amyloid or not, which are phase 3 in their latest stages, capable of identifying definitive positive outcomes, meaningful outcomes clinically, which are due over the next years to reveal their answers. There are some 62 early phase clinical trials at a variety of targets, 3/4 of them not amyloid. These are the results of basic science, which has found more and more potential targets. So the clinical trials or investment in them critically important. You alluded as well to the burden on families and those living with dementia. That is also an area of clinical research, clinical trials. We now are funding a large number of trials studying interventions for care and care providing, which will be producing their results
The National Academies identified 2 of those generated with NIH funds that are ready for dissemination, being disseminated with further evidence. Happy to elaborate as time allows, but these are some of the examples that of accomplishments and of our important process to continue being accountable to ourselves, to you, and to the public for making the best use of these very critical funds to accomplish the highest of priorities.
Well, thank you. And I think transparency is really important. This deadline's right around the corner, and we've put out a lot of money for this, and we need to know as a Congress how those investments are going. So look forward to working with you. And Senator Blunt, look forward to working with you on that as well.
Thank you, Chair. Dr. Tabak, during the time you were Deputy Director, the 7 hearings we had with Dr. Collins, who was the director at the time, I think every single time he talked about the importance of NIH bringing hope to millions. I want to talk a little bit about the proposed ending of funding for the Undiagnosed Disease Network. We have one of those in St. Louis. Chair Murray has one in Seattle. I had somebody reach out to me a couple of weeks ago, Michelle Herndon from Afton, Missouri. She was concerned because her son Mitchell, who had suffered from a series of health issues that doctors couldn't diagnose, had benefited from one of the centers. In fact, by late high school, he was in a wheelchair. His hearing was gone. His eyesight was gone. They were losing hope. But after they sought treatment at the Undiagnosed Disease Network in St. Louis, they found a neurological condition so rare that didn't even have a name. In fact, Mitchell lost his battle. The condition he had now carries his name, the Mitchell syndrome. But Michelle and her family were comforted by the fact that they finally knew what this long struggle had been about. This year's budget cuts the Undiagnosed Disease Network and closes all 12 of its clinical sites. She was concerned about that. I am too. I think there's some discussion, well, they may graduate in some way to where they continue to exist. I think it'd be a problem to walk away from that. Not everybody can come to NIH in Bethesda. And if you don't have a site within some reasonable distance of where you are, you're unlikely to get this service. Do you want to talk about why that decision was made to stop funding these 12 sites?
We certainly agree that the diagnostic services provided by the Undiagnosed Disease Network are extremely valuable to patients and to their families. The challenge that we face is there does come a point where diagnoses become part of standard care versus a research question. But finding that right balance is something that we continue to work through. All the cases that are enrolled presently will continue to undergo comprehensive evaluation. We will establish a data management and coordinating center to draw upon the experience of all of the centers that are participating in this program. But really, we'd like to work with you going forward to come up perhaps with a better solution in the mid and long term.
Good. Well, let's continue to work on that. I mean, you can't have standard care if you are still discovering things that need to be looked at as an option. Mitchell syndrome is Mitchell syndrome only because he was the first and maybe the only diagnosed person so far that ever had that, and that's going to fall outside a standard care definition, I think. So let's continue to work on that. Is Dr. Gordon available? Let me ask him on the RADx, Dr. Gordon, in the mental health area, in the RADx example of, again, NIH itself partnering directly with others to try to find a rapid solution. Do you think that Shark Tank, RADx kind of option would be a possibility as you look for biomarkers in mental health?
I think that's a great idea, Senator Blunt. I appreciate your support of of that initiative at NIMH as well. We have funded a number of small businesses as well as a number of academics who have come up with really wonderful ideas for biomarkers that can help guide clinical decision making, something that we desperately need in psychiatry to help speed treatments and make sure that people who need treatment get the right treatment from the get-go. And one of the ideas we've been thinking about is using the RADx example, where you had essentially a competition between a number of different companies, and RADx was for tests for COVID. But the idea is to apply something like that to the biomarker space for mental health, and we think now is the right time to do that. So we're talking with our colleagues at NIBIB who ran the RADx competition and trying to figure out how we can do that for biomarkers for mental health.
Well, good. I'd encourage that. I think every single home test for COVID comes out of the RADx experience. And again, if you've got people that have ideas that can come to you and try to see which of those you should partner with, I think that would be a great step in the right direction. Thank you, Chair.
Senator Reed.
Thank you, Madam Chairman. Dr. Gordon, we are in the midst of a significant spike in suicides, particularly among children, which is very disturbing. And we know some of that's a result of the pandemic, but I'm just interested in what research at NIH is pursuing this issue to recognize warning signs. How is that research being operationalized and put out to practitioners, particularly, and to families? And then the other point would be, we have a new national hotline, 988. Are you in any way sort of trying to coordinate or work with that or study that?
The answer to both those questions is yes. We're deeply involved in making sure that our research informs practitioners both in the clinic and at the state level when we're talking about 988. Let's talk about youth suicide first. NIMH has funded a number of different research programs in identifying individuals at risk, particularly the young, and in getting them to evidence-based care. One quick example, the NIMH intramural program developed a screening questionnaire called the ASQ that has been disseminated to primary care practices and pediatric emergency rooms throughout the country, and really it's being used nationwide. We also have funded a number of research projects looking at school-based identification and prevention measures as well, and we do our best to make sure that they're out there. We also work with federal partners like the Substance Abuse and Mental Health Services Administration, or SAMHSA, and there we're working with them, especially around the 988, looking to try to make sure that states that are implementing the follow-ups to 988 are aware of evidence-based approaches to mental health crises. For example, the proper utilization of mobile crisis teams that are trained in responding to individuals in mental health crises is one evidence-based approach that has been proven over and over again to work. So yes, and we continue to work in both those areas. Thank you.
Thank you, Dr. Gordon. Dr. Fauci, the issue of long-haul COVID has been dominating the news lately. And can you describe how NIH is tracking these cases? Are there common elements to them? And are there treatments showing any promise? Where are we in this process of tackling?
Yes, thank you very much for that question, Senator. I will begin the answer, then I'll hand it over to Dr. Gibbons, who's also very much involved in this.
Thank you.
As you well know, this is a real phenomenon, and the epidemiology of it is still being worked out. I mean, the range of people, anywhere from 5% to up to 30% of people have the persistence of symptoms that are not thoroughly explainable by any pathogenic process that we've been able to identify. We put together large cohorts that are now being followed, both to understand the actual prevalence, incidence, as well as the pathogenesis. With regard to treatment, Senator, it is very difficult to do any treatment for it when you don't know exactly what the pathogenic mechanisms are. And that's the reason why we're putting so much effort into trying to find out just what is going on. Is it immune activation? Is it persistence of virus, not necessarily replication-competent virus, but maybe particles of virus such as the nucleotides? But let me hand it over to Dr. Gibbons, who could also tell you a bit about that.
Thank you.
You know, I'd only add to Dr. Fauci's comments that we are indeed setting up the Recover Researching COVID to Enhance Recovery effort. It is moving with a great sense of urgency given the suffering of the patients with long COVID. There are a number of elements that have launched very effectively. One is to create an electronic health record based set of cohorts. They're derived from 60 million records of patients across the country, a diverse body of patients, of which between 4 and 5 million have COVID, and that provides an opportunity to track those individuals electronically and digitally, longitudinally, to see who develops long COVID, who does not. That can inform, as Dr. Fauci mentioned, our understanding of the prevalence, as well as the risk factors, as well as the long-term effects very chronically. It's already starting to show preliminary evidence that's suggestive of potentially the ability of vaccination to prevent the development of long COVID. Similarly, we're seeing signals that are telling us that the severity of the acute COVID has bearing on your susceptibility to develop long COVID. Similarly, we're seeing trends toward who's most affected. And again, it's identifying people of color, African Americans, Latinos, as a high prevalence group developing long COVID that really hasn't come to the fore as much. And so we're learning as we go and develop this program. Thank you.
Thank you very much. Just a final point, if I may. We have to reauthorize the STAR Act. It's the best thing we've done in a long time with respect to childhood cancer, and I think you agree, Dr. Tabak? Just a nod of the head is sufficient.
Yes.
Thank you. Thank you, Madam Chairman.
Senator Kennedy.
Thank you, Madam Chair. Dr. Tabak, what the National Institutes of Health has done is, and continues to do is nothing short of extraordinary. I mean, it's really breathtaking, and I want to thank you and your colleagues for doing that. We've all been to pandemic school for the last several years, and I want to use the few minutes I have to explore what we have learned. Dr. Fauci, whether you asked for it or not, you've sort of been the government's face on a response to the pandemic. Looking back, and I recognize that hindsight is crystal clear, but looking back, do you think it was worth it? Do you think the benefits were greater than the costs of closing down our elementary and secondary schools?
I think that's very difficult to give a definitive answer to that. I know in the very beginning, when we had really no other protection prior to vaccinations that were available to contain somewhat the spread of the virus, one of the things that was felt to be important would be to protect children as well as the rest of the population. Right now, we have felt more than just recently that it's very important to keep the children in school for the simple reason that we know of the deleterious effects, both psychologically, mentally, and developmentally in children, to keep them out of school. But you have to have a delicate balance between protecting the children from getting infected and perhaps bringing
Did we strike the proper balance?
You know, I believe that we have. It's very tough to tell. I think only time will tell whether that's the case, because there is indication that has been deleterious effects on children. But we believe from a public health standpoint that at the time it was the right decision.
Well, can I ask you this, Doctor? And I realize I'm not saying or offering a judgment on what was done at the time. I'm asking what we've learned. Let's suppose we had a substantial increase in prevalence of the coronavirus next week, God forbid.
Right.
Would CDC recommend shutting down the elementary and secondary schools?
It's very difficult for me to speak for the CDC, but knowing the fact that we
Recommend it?
right now, I would do everything we can to keep the children in school and not shut down the school. And that has always been my strong recommendation, to the extent possible, not to keep the children out of school,
But yet we
but
did
to
shut
keep
down.
them but to keep them safely in school by getting children that are available to be vaccinated, to get the children who are eligible to be boosted, vaccinated, and to surround the children with teachers and personnel in the school who are vaccinated. That is the best way to protect the children while keeping them in school.
Okay. Let me ask you this. In hindsight, knowing what you know now, had you known it then, did we do the right thing in shutting down society? Would we have been better off saying, no, we're going to protect the vulnerable, the elderly, the people who are immunocompromised, and we're going to isolate them, but have the rest of American society, churches, businesses, universities, schools, go on about their business, while at the same time providing them guidance about how to protect themselves?
Well, it's a complicated question. I'll try and give as simple an answer as possible. I think there's a misperception about who the vulnerable are. There are many, many more vulnerables in society, and there's a misperception that the only
yes,
vulnerables...
Sir, but I'm about to run out of time. Let's assume that we can agree on a definition.
I don't think you can. I think that society is very heterogeneous, and it isn't a question of shutting down completely, Senator, because we never shut down completely. If you do shut down a society, you do it for a purpose. And the purpose is at that period of time when you're protecting people from interaction, that you get as many people vaccinated as you possibly can.
Let me stop
to
you,
shut
Doctor.
down.
I'm going to run out of time. Let me ask you one last
Sure.
question. What would you do differently today?
Right now, I would hope that we would get many more people vaccinated.
No, but what would you do when you did it, in hindsight, if you knew then what you know today?
It depends on when we got the vaccine. Do you mean before the availability of vaccine? Before the ability of vaccine, when we had no other situation, I would try to protect people by making sure that they masked and they kept themselves separated from this congregate indoor settings. That's what I would do in the absence of a vaccine. But right now, I think it's important looking forward. We still only have 66% of the total population vaccinated, and less than half of those are boosted. I think we can approach what we are likely going to be seeing now with an increase in surges, with the possibility of a surge in the fall and winter. One of the real things we can all do as a nation is pull together and try to get our people vaccinated, and those who are eligible to be boosted. That would solve a lot of the problems that you're referring to.
Okay. Thank you.
Thank you.
all.
Thank you. Senator Baldwin.
Thank you, Madam Chair. Welcome, Dr. Tabak. I am posing the first question to you for an update on research efforts to better respond to the substance use epidemic. By way of context, as you well know, the substance use epidemic continues to ravage communities across Wisconsin and across the United States. And an increasingly dangerous role is played by synthetic opioids such as fentanyl, as well as psychostimulants like methamphetamine. So I believe it's vital that we invest in sustained research into substance use disorders to prevent deaths, treat patients, and make our communities safer. If you could describe recent research efforts, including what's happening with the HEAL initiative, the Helping to End Addiction Long-Term initiative, I would appreciate that.
If I may, to turn to Dr. Volkoff, who is our expert in this field.
Absolutely.
Thanks very much for the question. And the research is actually going from the basic to help develop medications with new targets, to help develop formulations that can be actually lead to better outcomes, to epidemiology research to understand the changing face of the overdose crisis, which now, as you are mentioning, is no longer just limited by overdoses from prescription opioids, but encompasses overdoses from fentanyl, methamphetamine, and cocaine, to implementation research that can help us determine what are the optimal models of care that we can deploy in community and that take advantage of infrastructure. So, for example, research is ongoing to determine how the healthcare system can be involved in the prevention and treatment of substance use disorders. How can we bring treatments to justice settings like prisons and jails and upon release and maximize the feasibility of these individuals to get healthcare, to the involvement of communities so that we can actually integrate the effort between healthcare, justice, and communities. Through the HEAL initiative, we have been able to accelerate significantly. Also, another area that has been neglected overall, which is the need to better treatments for the management of severe pain. And if we do not address the need of patients suffering from severe pain, we may keep them as being very, very vulnerable to seeking out much more dangerous drugs out in the illicit market. And finally, we need to also ask ourselves, what is it in the United States that is making Americans so vulnerable to the use of these drugs? And that is very relevant to prevention, because if we do not understand it, then we cannot do interventions to actually protect those that, because of circumstances alien to them, are actually at much higher risk of taking drugs and ultimately develop addiction or overdosing.
Appreciate your response. Dr. Fauci, the U.S. was able to bring a COVID-19 vaccine to the public in really record time. And I'm grateful for the work of so many that made that possible, including several who are in this room. Unfortunately, the next pandemic, driven by an unknown disease X, will come. And I believe we can't wait. We should invest in the development of novel antivirals and vaccines and diagnostics for unknown threats from priority viral families now, so that we're better prepared in the future. Can you explain how the investments we've made over time at NIH and across the federal government made the COVID-19 vaccines and medical countermeasures possible? And how would sustained investments to develop responses to viral families of concern make us better prepared?
Right. Thank you very much for that question, Senator. Yes, it's very, very clear that the investment in basic and clinical biomedical research for at least a few decades and maybe more prior to the realization that we were dealing with a new historic pandemic allowed us to do something that was completely unprecedented. Two examples of that are the work that was done on what we call vaccine platforms, the mRNA vaccine, which was fundamental basic research on how to get the mRNA molecule to actually serve as a platform for vaccine. Work at the NIH in our own campus, as well as NIH-funded investigators throughout the world, also worked on what's called immunogen design to do work that led to the ability to stabilize the optimal immunogen. In this case, it was the spike protein, which allowed us to go from realization of a new pathogen on January 9th, 10th, 2020, getting into phase 1 trial in 65 days and 11 months data, having a safe and effective vaccine. We did that because of the investment you're referring to. Right now, looking forward, we have what's called a prototype pandemic preparedness plan, which means you do just what I believe you're alluding to. You develop a number of families. There are about 20 families that are the high risk. Of those, there are about 7 families of viruses that if you do the fundamental work of looking at the commonalities among them and develop diagnostic tests, assays, immune correlates, and do that now. And if we don't get the resources now, Congress has been very generous to us up to now, but if we don't get the resources we need, we're not going to be able to do the kind of preparedness, not only for vaccine, but also for targeted development of antivirals. which we did so successfully with HIV and did quite successfully right now, but we have programs that are not going to get off the ground unless we get funding. So fundamental, basic, and clinical research are the core of everything that's going to protect us in the future. Thank you.
Senator Braun.
Thank you, Madam Chair. So I'm going to have two questions, and I'd like Dr. Tabak and Dr. Fauci to answer each of the two questions. I'm going to start with this one. So in navigating through the entirety of what we did to fight COVID, clearly the most expensive feature of that navigation would have been lockdowns. We did that out of uncertainty. We had no idea, how that was going to work. Even in the business I ran, you had early dust-ups where you'd get a case and clear out a warehouse. We quickly understood you don't throw caution to the wind, and you take the basic information that we all had to deal with, and you took it seriously. You put protocols in. Let's look at lockdowns. Cost us trillions of dollars. And, we're paying for that now with super high inflation. And I think I'm interested in when Johns Hopkins comes out with a study that said basically that didn't have any impact on mortality. And I don't know that that study addressed what mortality might have been impacted in terms of deferring other, health care. Can we take lockdowns off the table in terms of what we do in the future? Dr. Tabak and then Dr. Fauci.
I can't say because I don't know what that future holds for us. If you have a pathogen that is very virulent, very infectious.
Let's assume it's in the same modality as what we've been navigating through over the last couple, 3 years.
I think the initial presentation of the virus was one that was devastating. It killed a lot of people.
What about the study that Johns Hopkins did? Because we're always saying pay attention to the science.
I'm not familiar with that study, sir.
Dr. Fauci.
That's a very good question. If you're going to lock down, you've got to use it temporarily for a reason to prepare you to be able to unlock down and get the public prepared for that. Right now, looking forward, I don't see the need of lockdown in the future unless something really very, very unusual happens. And the reason is that what we really need to do is we need to get our population vaccinated and we need to get them boosted. That would completely obviate the need to lock anything down. So right now, if you ask me the question, looking forward, do I see, even if we do get a new variant, I think the vaccinations that we have enough cross-reactivity and our ability with proper resources to make variant-specific boosts. I don't see lockdown in the future. Lockdown is a temporary thing to get you to be able to move quickly to save lives.
That is good to hear because in that kind of moment of uncertainty, I don't think we could afford to do it again, and I hope the Biden administration is listening to that. Other question, I led the effort on it. It is when we took this and distilled it down to you either get a vaccine or you lose your job. And thank goodness we did marshal bipartisan support that said that didn't make sense. Supreme Court used that as a cue, in terms of what they did to abrogate that. So in the future, will we heed what the Supreme Court said and that you wouldn't calculate, even though don't disagree that vaccines are an important tool along with therapeutics and preventative. Would you push to do the same thing that we almost did that would have been the second calamity to occur in terms of what it would have cost the economy and probably not benefit, from a result that would have been measurable? Dr. Tabak and then Dr. Fauci.
As you know, the vaccination is the single most effective preventive measure, and so to the extent that the law allows, you would want to continue to.
But would you recommend that we go down that path again, down to 100 employees in a business to where you said either get it or lose your job?
That's a policy call, sir. I don't make those calls.
Dr. Fauci.
Again, it's a policy call. I would hope that we would marshal everybody, both sides of the aisle to get out there and encourage everybody to get vaccinated. And if they did, we wouldn't even have to address that question. I don't like mandating things. I don't like punishing people for not doing something, but I would hope that they would realize if you look at the data, and you just made an appropriate statement, Senator, a moment ago about following the science. If you look at the data of the differences in vaccinated versus unvaccinated people and hospitalizations and death, it's striking what it is. So as a public health person, I would say, why don't we all pull together to get people vaccinated? We wouldn't have to worry about essentially putting what appears to be and is, in fact, a penalty if you don't.
And I think the key to that navigation is pay attention to the data and the science, not the political science.
Right, exactly. Thank you.
Thank you. Senator Rubio.
Thank you. Thank you all for being here. Thank you all for being here. Dr. Tabak, let me start with this question. We've recently seen that not just the Biden administration, but the Biden administration and others in the policy realm have been actively promoting and supporting the use of things like puberty blockers and hormone therapy for young boys and girls. I want to sort of limit my question to minors for what they have termed gender transforming care. That's not an FDA-approved use for puberty blockers and hormone therapy. I don't believe in any people, but especially in minors. So as the NIH is America's medical research agency, what work have we done at NIH, what work's been done to determine if this non-FDA approved use of these medicines, this off-label use of these medicines is appropriate for minors seeking gender transforming care?
So NIH funds a small number of observational studies to gather the data on the effects of treatments that transgender youth and their parents have chosen. And there are also a small number of studies that describe the health issues and risks, including HIV, that are unique to these transgender youth. But all of the research in this space is observational. We do no interventional work.
I guess my question is, before, one thing is a decision made by an adult, right? And especially given the irreversible nature of some of these treatments, isn't there some wisdom in the notion that before policymakers are out there promoting the off-label use of medications that lead to permanent changes, that there be some more research done on its impact 5, 10, 15, 20 years from now?
So, as you know, transgender youth are more vulnerable to depression, anxiety, engaging in self-harm. And so it is important that we examine and evaluate the potential effects of these treatments. Researchers are observing longer-term psychological impact of these protocols. And so by looking at individuals, transgender youth with and without histories of puberty suppression, we'll be able to better answer the types of questions that you're posing.
Yeah, I guess that's my point. My point is we don't know what its long-term implications are when we weigh the costs and the benefits. The FDA hasn't approved this, and yet we have policymakers promoting it. And I think that's an important point. I mean, clearly don't want anybody harming themselves and things of this nature, but we don't know what these policy decisions are being made on the basis of observational guidance and by your own admission without any sort of long-term trajectory on its holistic impact. Dr. Fauci, I'm running into something that's pretty interesting. I believe the United States is the only major Western country that now requires its citizens to test negative for COVID before they can get on an airplane and re-enter the country. I believe that's accurate. And on the other hand, we're hearing now that, for example, Title 42, which is a COVID-era policy, should be lifted because we've reached a point now where COVID is manageable or at a level where we no longer need Title 42. And we obviously know we have a problem in our southern border where every day people are entering the country illegally, and many are not even being tested for COVID. And even if they are, they're being allowed to stay, and most certainly would under Title 42. I don't understand. How do we tell American citizens if you test positive, even if it's dead virus that's been in your system for 10 days, because you can test positive days after you're no longer infectious, and you can't enter your own country, but people, if you arrive illegally, whether you test positive or not, if you say the magic words for asylum, you get to stay in the country. And this is a real life scenario. I know people that are abroad, they test positive, they're not sick, maybe they were sick a week ago, and they can't afford to continue to pay for hotel rooms and staying overseas until they can finally score a negative test. Has the time come for us to lift this, in your view, having been so integral in our COVID response? Are we at a point now where American citizens should be allowed to return to their country without testing negative?
I'm not. Thank you for the question. It's an important question. I don't have the answer to that. I mean, we work with our CDC colleagues to continue to examine the feasibility of that and the desirability of that. I think the idea of having an immigration issue mixed with a public health issue for the general population, I think those probably should be separated.
Well, except they're interrelated because they're both involve groups of people entering the United States. One group is citizens of the country entering legally. The other group, frankly, are people that are not entering legally. The group that's not entering legally, even if they test positive, if they're even tested, get to stay. The American citizen can't re-enter their own country until they produce a negative test. And my point is, if we've reached a point in COVID where we no longer need Title 42 as a COVID restriction for illegal entry, why do we still need travel restrictions for American citizens for legal entry into their own country? That's the genesis of the question. That's where I think the link is. It sort of seems to be at odds with it.
Yeah.
All right. Thank you.
Thank you. Dr. Fauci, you talked a little bit about this, but I wanted to go back through it again. I am really pushing for Congress to pass additional emergency COVID funding to make sure that our communities have the tests and the treatments and vaccines they need to keep their families safe. And I understand that your institute is supporting research on the development of these next generation vaccines that could protect against multiple variants. What can you tell us about the progress of that research, and what does that NIH need to see it to completion?
Well, thank you for that question. Well, the progress has been substantial. To get what we call universal, and that's probably too broad a term, is to get a vaccine that works against multiple variants of SARS-CoV-2 is the first step. And that would be something where you get a vaccine that either is directed against a common component of all of the variants or has each of the components of the variants, for example, in a nanoparticle with a mosaic or multiple components to it. We have studies that are right now gone from preclinical, namely in an animal model, into a human study. And the results actually look very promising. The next step would be to get a vaccine that not only is against all variants of SARS-CoV-2, but against all of those group of variants, including what we call sobecoviruses, which overlap with the viruses that we see in many bats, which almost certainly are the original source of these viruses that have jumped species and gone into humans. The work is going along very, very well. We're getting a number of investigators, both people who've been established in the field and new investigators, but we can't continue it, Madam Chair, without additional resources. And that's really one of the things that is very, very difficult for us because the scientific opportunity is there. And we really feel that we do have this not only as an aspirational goal, but we will be able to get to that goal of getting a vaccine that would protect us against both known and unknown variants. So we're excited about the science of it, but we can't continue without additional resources.
Don't have resources, right? And how is your institute working with BARDA to accelerate innovation in the next generation vaccine development, particularly for COVID-19 vaccine?
Well, we've had a long-standing collaboration and cooperation with BARDA now for quite a long period of time. And the way that works is that we do the fundamental basic research and proof of concept and very often get involved not only in the preclinical but in the early trials, whereas BARDA partners with the pharmaceutical company to do the advanced development of these concepts. So it's a partnership that has really worked very, very well, and hopefully we'll be able to continue that again with the need for new resources.
Okay, thank you. Dr. Gordon, I want to come back to you. You've had several questions about mental illness. Not surprising, it's a huge issue for America today, and I know that the despite the best efforts of researchers like yourself in the past 30 years, we have seen dramatic increases in mortality, morbidity, and healthcare costs related to mental illness. And that is actually before factoring in the effects of this pandemic and the opioid crisis. And on top of it all, diagnosis is really difficult, and medications don't always work and can have awful side effects. So I know Senator Blunt asked you about using RADx as one possible approach, but what are the greatest barriers to accurate diagnosis?
Well, frankly, one of the greatest barriers to accurate diagnosis, Senator, is that our diagnoses are not terribly good in terms of describing what's actually going on in the brain. And so we need a better individualized approach, not just to diagnosis, but really to being able to make informed clinical decisions in cooperation with our patients. Well, the clinical issue really isn't, does this individual have depression or schizophrenia or bipolar disorder, although those diagnoses can be sometimes hard to differentiate in individual patients. The bigger clinical question is, for this patient with depression, are they going to benefit most from a medication, or which type of medication, or are they going to benefit most from a psychotherapy or a brain stimulation treatment? We have a number of different research projects that are aimed at trying to make those kinds of clinical decisions with the aid of technology, with the aid of increased attention to details in the patient's behaviors and cognitions. And that approach, I think, is going to take advantage of things like big data. So we need to collect lots and lots of information about well-characterized patients. And then we need to make careful experiments to try to determine when that information helps us describe that patient better. So it's really about precision medicine and psychiatry, moving it forward in a number of different fronts, from grants to academic organizations, and as I mentioned also before, small business grants that are really paying off. So we should see some progress, hopefully in the future, near future.
So I assume it's fair to assume that solving this diagnosis puzzle would really open doors for better treatments?
It would open doors to transforming how we decide with our patients what treatments to use. It would really change psychiatry. Right now, as a psychiatrist, if I want to help someone with depression, our only discussion is about which side effects they don't want. And so we try to avoid one medication or another, as opposed to which medication or which treatment that I have to offer is going to work better for them. So yeah, it would really transform things.
Okay, thank you. Senator Blunt.
Thank you, Chair. Dr. Hodes, I've been watching the FDA decision on Aduhelm, the Biogen drug, as well as the CMS handling of that. I think that decision is going to have some pretty long-term consequences, particularly the CMS decision. And other companies will be following. Biogen's already made some pretty dramatic decisions based on the CMS view that only the people in the trial could benefit from the emergency approval by FDA. Would you talk a little bit about both of those things? First, the FDA approval process. What merit do you see in that emergency approval process? And then what concerns do you have or not have about CMS then deciding that it would only be available to a few people?
Thank you for the question. Well, of course, FDA and CMS have their regulatory responsibilities, and we defer to those, but we do work very closely, in particular on the science involved in its implications. So as many or all of you may know, the decision by FDA was what was called an accelerated approval of aducanumab, Aduhelm, based on its ability to clear amyloid from the brain and by brain scans without a compelling evidence of clinical effectiveness. And that was the rub. And in fact, the FDA decision required that the sponsors, Biogen, Eisai, then conduct a randomized controlled trial to determine if there was, in fact, clinical outcome. It was in that setting that CMS said that for widespread coverage, it would require randomized controlled clinical trial. It made a distinction, though, about the future of such drugs. Any drug that received an approval based on clinical outcome, based on FDA decision and judgment, would have broader coverage without requirement for another randomized clinical trial, but any in which there was no demonstrated evidence of effectiveness on clinical outcomes would require that kind of outcome before they went further. Again, those are regulatory decisions.
So it sounds like to me the FDA decision was really, as CMS saw it, at least just a decision to continue the trial. That may not have been what FDA thought it was doing, but that's what CMS decided it was doing.
Well, FDA, again, by requiring that for maintenance, even of the accelerated approval, that a clinical trial, randomized trial, be carried out, was also saying there needed to be a continuation. You ask importantly, I think, what the impact of this will be on other studies, other agents. There are currently 3 companies, Roche, Lilly, and Biogen, which have ongoing clinical trials of other antibodies to amyloid. They've all received a breakthrough designation last year from the FDA. They're all expected to produce their results in the next few months. So above all, I think we all share hope and optimism that we'll see effective clinical outcomes there. For NIH, I think the implications are clear. We need to support the most rigorous and continued research toward amyloid and other targets, the kind of research that will give clear-cut, definitive answers about clinically important outcomes. And that's certainly our part in this consortium.
Well, Dr. Fauci, while we're talking about accelerated approvals or not, during COVID, obviously NIAIDs shepherded both successful vaccines and therapeutics through the approval process during the pandemic. I'm concerned that once the pandemic is officially behind us, that both vaccine and therapeutic research and development will be subjected to normal development processes that, in what we've learned in the last year and a half, may not be the structure that we should use. Would you talk about that a little bit?
Senator, are you referring to the fact that we should not slow down the acceleration of approvals when we're out of the pandemic phase?
I'm asking if that, or if there should be some new normal approval process that now that we've had, I think, 2 vaccines and 20 treatments developed through those partnerships.
Yeah, I'm not sure I understand the question. It's my fault. Are you saying that should we continue the normal standard of approval, which would take much longer than the emergency use authorization? Is that the question you're asking?
That's the question.
Yeah. I think we should go through the normal approvals, and if we're in an emergency situation, again, we absolutely should use the EUA approach, which has fared us very well. But when we get behind us the outbreak, I think the normal approval process, which is pretty much expedited pretty well by the FDA, should continue.
All right. Thank you, Chairman.
Senator Kennedy?
Thank you, Madam Chair. Did the Biden administration ask any of you whether it was safe to rescind Title 42?
We've had no discussions about that, sir.
You haven't, Dr.
I have
Taylor?
not, no.
How about you, Dr. Fauci?
No, I have not.
How about you, Dr. Gibbons?
No, sir.
How about you, Dr. Gordon?
No.
Dr. Hodes?
No, sir.
Dr. Volkow? Well, the Biden administration says it's safe, that under the science, it's okay. Who did the administration rely on to suggest that rescinding Title 42 is in the interest of public safety?
That was a CDC decision. The Title 42 is a CDC decision.
Do you agree with it, Dr. Fauci?
Well, I think that the immigration policy should be separated from the public health.
And I don't want to get you involved in immigration policy, but people are people. Physiology is physiology.
Right.
And one's susceptibility to the virus has nothing to do with their country of origin or their immigration status.
Right.
And what I'm asking you, purely from a public safety standpoint, is it safe to rescind Title 42?
Yeah, I think given the level of infection at the time, which is right now, that I think that the CDC decision was a reasonable decision.
Does anybody disagree with that? Do you all agree with that? Let me get you a record. Dr. Gibbons?
Yes.
I concur with Dr. Fauci on that.
Dr. Gordon?
I don't have the expertise to concur or not concur.
Okay. Dr. Hodez?
I would also say I don't have the expertise to weigh in on this.
Dr. Volkow?
I don't have the expertise.
Okay. All right. Thank you very much.
Sen. Moran.
Thank you, Chairman Murray. I don't have the benefit of knowing what's been asked and answered, so I'll ask my questions. And recently, the ARPA-H proposal would initially focus. This is for Dr. Tabak. Would have initially focus on 3 diseases: cancer, Alzheimer's, and diabetes, and be housed under NIH. Congress and NIH already invest significantly into research and development into these 3 diseases. How can NIH conduct proper oversight to ensure NIH's current work isn't simply being replicated?
I think those 3 diseases are meant to be illustrative and not restrictive. In terms of the larger issue that you raise, as you know, NIH does rather extensive portfolio analyses, and the expectation would be that there will be a crosstalk between the new agency and the NIH to avoid, as you put, the potential for duplication.
This again for you, Dr. Tabak. In recent national coverage determinations, CMS indicated it would support FDA and NIH by covering drugs for Medicare beneficiaries participating in randomized controlled trials. I would interpret that to mean that there is a path to coverage through NIH studies for participants qualifying trials related to any FDA-approved Alzheimer's disease treatments. Is that an assessment that, and if not, if that's an accurate assessment, or how would you elaborate?
If I may turn to Dr. Hodis, who's the expert in that space.
Dr. Hodis.
I think that's a very accurate statement. Thank you.
Good. That's a good development, right? Dr. Hodis shook his head yes.
Yes, sir.
Let me talk a moment in the absence of Dr. Sharpless. I'll let you all direct who should answer my question. The NIH 23 budget request suggests a $199 million cut to the NCI, a 2.9% cut from the current fiscal year. I assume that will be explained as those dollars being picked up in ARPA-H. What's the rationale for a significant funding pivot to ARPA-H at the expense of NCI?
So at the time the budget was prepared, the only baseline that the administration had to work with was the continuing resolution level. We're very fortunate that the Congress in the omnibus provided us with substantially more resources than were in the continuing resolution, and we certainly look forward to working with you as the 23 appropriations process works through.
So there's room, there's no particular insistence that that's the right ratio between the funding at one ARPA-H and the normal appropriations process for NCI.
I think it's more a reflection of using a baseline that was available at the time.
Well, the $16.9 billion increase for NCI and FY22 allowed the NCI to increase the funding allocated toward competitive cancer grants. It's one of the reasons we continue to advocate for higher NCI funding is to improve NCI's ability to award those competitive cancer grants. In recent years, NCI could only fund about 1 in 8 research grant applications. Dr. Sharpless indicated in front of this subcommittee that was a great concern to him, as it is to me. If NCI funding is not boosted above the FY22 levels, can competitive grants be prioritized and expanded?
it would be very difficult to do that in the absence of additional funding.
Doctor, thank you, both of you. Thank you all.
Dr. Tabak, last week the National Academies issued its review of NIH's autoimmune research portfolio, and the authors found that much of the work that that agency does in this area is really extraordinary, but that NIH doesn't do the best job coordinating or setting priorities or focusing on innovation or evaluating its autoimmune research portfolio. The authors' findings really echo an earlier 2010 National Academy study on women's health research, and to address these problems, they recommend the creation of an Office of Autoimmune Disease Research within the Office of the Director to facilitate collaboration and coordination. Given the importance of this research for communities across the country, it's really critical that NIH does the best possible job facilitating it. Do you have concerns with establishing this office?
Senator, the report, as you know, was released last week, and we're still reviewing the specifics of it. In reviewing the top-line messages, among the things that they suggest that we do, develop an agency-wide strategic plan, make sure that investments that we make align with those strategic plans, coordinate both within and outside the agency, do evaluation, do reports to the Congress. At first glance, I think these are things that we could probably do without the creation of a new office, but I certainly, would be willing to work with you and other members of the committee going forward as we sort through the specifics of the report and get a better understanding of the rationale behind their specific recommendations.
Okay, I'd like to work more with you on that. I think this is extremely important. I want to make sure we're addressing it in the correct way, and I want to talk to you more about that.
Thank you.
Senator Blunt.
Thanks, Chair. I think my last question today will start with Dr. Tabak, but anybody that wants to talk about it. One of the things we were most concerned about 8 years ago was the fact that young researchers were just leaving the field, that the pool of money not only wasn't increasing, but was about 22% less in research buying power than it had been. What are we doing right now to keep young researchers in the field and try to see that they get their first grant and that there's not an obstacle based on numbers of first grants to getting that second grant? Why don't you start, Dr. Tabak? And if anybody else wants to talk about what you're doing to keep young researchers engaged, I'd be pleased to hear that.
We've prioritized the funding of early stage investigators. Back in 2013, we only supported 600 such individuals. Last fiscal year, 1,513. That's come as a result of the Institute and Center leadership prioritizing applications from these individuals. We have also created certain mechanisms that would incentivize and enable early stage investigators. So, for example, we have the so-called CATS Early Stage Investigator Award, in which no preliminary data is accepted. This is important. It basically liberates a new investigator from his or her postdoctoral or graduate school experience, and they are able to think, as boldly as possible in preparing an application. We also have the NIH Director's New Innovative Award program, which is attracting early stage investigators from very broad biomedical fields. And so when you take these things together, I think we are making good progress in ensuring the entree into the system of biomedical research. But let me turn to my colleagues to see if anybody else wishes to comment.
I might add to Dr. Tabak's comments, and there are two areas for the NHLBI that we're particularly focused in on. As evident in these hearings, a critical element is the translation of basic science understanding into clinical science and clinical medicine. Clinician scientists are critical to making those translational leaps that are so important to public health. This is an area, quite frankly, where there's a paucity of early stage investigators and a critical pipeline. And so we have special awards for them to get their first, our R01 in particular, to launch their careers as early stage clinical investigators. I would also add the diversity of that early stage investigator pool is critical, and recognizing the supportive efforts to expand that diversity is, again, another high priority, which we have programs specifically designed to do that, like our PRIDE program. Over.
Anybody else?
I had to reinforce the points made and note that we also try to track outcomes of our programs, including training, career development. So, for example, with the expanded research around Alzheimer's and related dementias research, since 2015 through the present, fully a third of the investigators awarded have been new and early stage investigators who've had no prior major NIH research. And we take this as an important reflection of our ability to recruit, and now we'll see about retaining them into the research workforce.
And I was just going to make a comment because Dr. Tabak alluded to it, and an area that is crucial is to ensure that we get the brightest interested on science. So going after younger kids and teaching them and giving them the opportunity to see what science is all about is a way that you can ensure that you will have the throughput then to get investigators.
Thank you, Chairman.
Thank you. Senator Moran.
Just take this moment, Chairman Murray, to thank you and Senator Blunt for your leadership and the success that we've had in numerous years now in a row in the support for the National Institute of Health. I've been the ranking member of this committee with Senator Harkin. You both have been ranking members and chairmen and women of this committee during a period of time in which we were capable in a bipartisan way of increasing the investment in fighting the diseases and afflictions that Americans and people around the globe suffer from. And not knowing what our committee's schedule is into the future, this may be the last time we have Senator Blunt here with the NIH crew. And I'd take this moment to thank him in particular for his efforts that have been recognized around the country and certainly in our home states of Kansas and Missouri of making a tremendous difference in the efforts to find the cures and the treatments to reduce the afflictions that we face in the world of our well-being, of our health. And so to you, but to Senator Blunt particularly today, thank you for that leadership. I'm pleased that the world is in a better position and Americans have a greater chance of fighting these diseases, and there's a lot more hope than there used to be.
Thank you. Thank you for those comments. I think we all agree. That will end our hearing today, and I want to thank my fellow committee members for a thoughtful conversation. I want to thank Drs. Tabak,